Hi, everybody. I hope everyone can hear me. I'm Ramya from Team Marbles Health. Welcome to today's webinar titled Identifying Treatment Gaps in Psychiatry and Integrating Neuromodulation into Clinical Practice. This is a series of webinars. So, we are starting a series of webinars um, in an as an academic pursuit. Uh, for doctors in India to understand neuromodulation better and to be able to adopt neuromodulation into their practice. So this is the first of such webinars, and we'll jump into it. A little background about why neuromodulation is relevant today. The brain is fundamentally an electrochemical organ, functioning through both chemical signaling and electrical activity. Traditionally, psychiatric treatment has focused largely on the chemical imbalance that mental disorders have, becoming the gold standard of psychiatric care. This is largely because medications are very easy to scale, they're also very affordable. Over the past decades, the electrical imbalance, there's been a lot of extensive research going into how to rebalance the electrical activity that is imbalanced in different psychiatric and neurological disorders. This has led to more and more research and advances in neuromodulation therapy that directly influence the brain networks in a non-invasive and safe manner. Today, neuromodulation has reached such a level of scientific maturity that just last week, tDCS has received an official US FDA approval, reinforcing the clinical relevance of neuromodulation, scalable neuromodulation in today's context of psychiatry. So essentially, again, the goal here is that neuromodulation is becoming a second pillar of medical treatment, and we want doctors in India to also be aware of neuromodulation, where it's going towards, and to be able to integrate it into their clinical practice. So that's a little background about why neuromodulation is relevant today and in today's context. Um, Now, coming to our speaker of today, Dr. Krishna Sahithi is a consultant at Apollo Hospitals and has her own private practice in Hyderabad, in one of the best areas of Hyderabad. She has over 10 years of experience in psychiatry, specializing in a range of psychiatric conditions, specifically depression, anxiety, bipolar disorder, OCD, adolescent medicine, and psychosexual problems. She is also a member of the Indian Psychiatric Society and has published multiple articles in various journals. She is also an associate professor at Apollo Institute of Medical Sciences and Research, Hyderabad. Her approach is incredibly patient centric and evidence based, focusing on personalized care and multidisciplinary treatment. Her dedication to patient care has also led her to becoming one of the premier, flag bearers of neuromodulation in India, where she is one of the first person to take up neuromodulation and see the results of it firsthand on her patients. And yeah, she's now here today with all of us to discuss her clinical experience and what she's learned in this process, and how everyone else can also integrate neuromodulation into their everyday practice. A couple of things that we will be covering today. One is, what are the gaps in the current line of treatment from a psychiatrist's perspective? What are the practical challenges that doctors face on a daily basis? Is just medication enough anymore? And what are the search for better interventions? Existing options, and where do they fall short? And why tDCS is relevant today? The neurobiological rationale for tDCS, like exactly what is happening in the brain. Um, Again, what clinical problems does tDCS solve? Any challenges that might come up while doing tDCS in practice? Again, there are why to use ease from Marbles Health. What are the clinical considerations that made Dr. Sahithi choose ease over the other another device in the market? And Yeah, I think that's and further observations from her clinical practice. I think that's it from our side, from the Marbles Health team side. I would hand it over to Dr. Sahithi, who can, who we are all here for, and she can go over everything in detail. Thank you so much, everyone. And please drop in your questions on the chat interface. After the session is done, we would be happy to take questions, and Dr. Sahithi can have a live Q&A session with everybody. Thank you so much.
Thank you, Ramya. Thank you for your introduction. Coming to our today's topic. The gaps in the current line of treatment. What exactly is happening with us is more of when we are advising more of treatment, patients are not being adherent to the drugs which we choose, and there are more of dropouts. More of 43% of patients on antidepressants are dropping out, and there are more of psychiatric comorbidity. Like same patient is having more of depression, anxiety. The scales are more high in the severe mode. So the first we need to scale, like we need to start the treatment either with the antidepressants and the mood stabilizer slowly, and then we have to think of all these things. Whereas when we consider neuromodulation in these sort of patients, that would be of more help. What are the challenges which we are facing daily because of the medicines is because of the side effects. First, patients are asking the doctor, are there any side effects for this? When we even how much time we have, we spend time with the patients that there are no side effects, please do continue and all also. But still, when they're facing this headache, sweating or dry mouth, they're discontinuing the treatment. When I had seen many patients having this sort of things with sertraline and escitalopram also. So they are causing early discontinuation. When we change the antidepressant to another one, and when still we are trying for 2 more days, there is causing so much fatigue, and they are not accepting. And more importantly, when they're having severe depression, severe anxiety, we can't treat the patient without giving an anxiolytic. When we are giving an anxiolytic, they are having so much of sedation, and that sedation is causing them to discontinue the treatment. Most probably, amitriptyline and clomipramine, fluvoxamine, they are getting discontinued. So the response also, when should we consider neuromodulation in these patients is like whenever there is a non-improvement with the medicines, and when we do the rating scales in the next visit when they come down, if the percentage of improvement is less than expected, less than 25% or less than 20%, it's better to consider neuromodulation in those cases. And even there is lack of proper response, and we have to check for the compliance also. And if there is any treatment resistant depression also, this only is more challenging and more better than conventional treatment. Why this is keeping pace is why the traditional methods are keeping pace is because of the underlying not proper compliance, and no proper caregivers in our psychiatric fraternity. There will not be no caregivers, and that is also in more of working class people. It's being difficult. So these people, as they are more of working class, and they are asking us more of non-sedative drugs, and antipsychotic medicines or any antidepressants. Having less sedation is very difficult. So we have to choose more non-pharmacological biological treatments. For that, when we advise the neuromodulation, we are seeing even after the first session, patients are saying they're feeling calm and better and more stabilized, and very less side effect burden. Some patients complained of headache, and we, instead of only thinking about the neurochemical imbalance and all, we are going at the network level, improving synaptic plasticity. What are the existing biological options, ECT, RTMS, and ketamine? With respect to ECT, there is a high efficacy for ECT, but there is a requirement of general anesthesia, and it is an IP procedure, and 7 to 10 alternate days sessions are needs to be done, and there is more of anterograde and posterograde amnesia. With compared to our tDCS, that's an OP procedure, no requirement of any anesthesia, completely non-invasive, and we can use as the first line along with the antidepressants. So we need not wait. That's how it is helping. And regarding the RTMS, it is also effective, but that is completely clinic bound. When compared to that, we can send the TDCS machine at home. Services also are available. So this is more of a clinic bound and very costly machines, RTMS, and it is taking so much space in our clinic. With respect to ketamine, there is a rapid action when we keep the patient on ketamine drips, but there is more of relapse, which I had personally experienced in my patients, and having some ketamine dissociation, and parents are getting tensed about that. So why we have to consider tDCS with respect to all these things is there is the direct modulation of this dysfunctional brain circuits, and it is just complementing rather than replacing the pharmacotherapy. Anything which we doesn't advise anybody no, to replace the pharmacotherapy. But for some patients, those who had previously got treated by us and they are doing better, and those who doesn't want to go with the pharmacotherapy when they are asking us, I am advising this. TDCS sessions, and they are feeling better. Like after about 3 or sessions, after about 5 to 10 sessions, when they are feeling better, I'm telling them to discontinue. And this is targeting the mechanisms of the medications that do not directly address. This is the neurobiological rationale for tDCS. And in this reflects dysfunction in the specific large-scale brain networks rather than the unitary diagnostic entities. And it also enables the selective modulation of these dysfunctional networks instead of diagnosis level stimulation. So as it is network based analysis, it links symptom dimensions to circuit level, either hyper or hypo connectivity. And this is increasing the plasticity. So what is plasticity is more of network connections, and it is targeting plasticity in specific networks so that desirable connections are being made. Both negative automatic thoughts and positive habits are experientially reinforced. And with respect to when compared to the medication, it induces only global plasticity, whereas this TDCS, it increases the target plasticity. So, what sort of problems does TDCS solve? So, when we advise the patients to go for this, immediately they're feeling calm, that executive control, that instability is coming down, and they're feeling better. And whenever there is incomplete antidepressant response, we are advising. And with tolerability, there is good tolerability. Only one, we have completed more than 300 sessions. Whenever there is any adherence issues and all, we are advising to come like once in every alternate day also, so that that will be helpful for the patient. For some patients, we are doing morning and evening sessions too, with a gap of 3 to 6 hours. And long-term treatment engagement, when we advise all these things, they are not ready. So they want to get it treated in 3 to 4 weeks of time. So that's how this is helping. It all depends upon the our practitioners' interest, like however we want to treat our patients, either it with the stimulation protocol or combined with this pharmacological treatment. What are the parameters which we need to tracking and monitoring of these sessions? But every 10 sessions, we are getting one report, and assessment is a moving target, tracking response, adherence, and unpredictable patient conditions. And sometimes this is being costly. For some patients, those who are not affordable, we are offering free treatments also. We have completed 3 patients with 20 sessions of free treatment also because of this cost thing for some. And practically this is not a standalone treatment. We need to go with the combinations. So uh, we are getting this has got a software, so we will enter the patient name and everything, so number of the sessions, and we can give the current stimulation from zero point 0.5 milliamperes to 2 milliamperes. Those who are not tolerating 1 milliampere or 2 milliamperes like that, we are reducing it to a zero point 0.5 milliampere or 1 milliampere, so that they are feeling better. And while the session is being done, they are playing these games. The Tower of London cognitive emotional training, Tower of London emotional and back, emotional go no go test, flanker chase test, trial making test, and attention bias modification. These tests are being done by the patients, and environmental stimulation is also there. So they're feeling good with this guided visualization programs. So we are advising 20 sessions each every day. If they needed 2 sessions in the morning and evening, if the patients are coming, if they're not interested in doing 2 sessions a day, we are doing every day 1 session. So that's how this is helping. Some patients are complaining of headache after the session, and otherwise they're okay. So this is what why is because, if the patients are not comfortable, we can reduce the current density, like from 2 milliamperes to 1 milliampere. When we are saying directly that to the patient that we are keeping this current to your thing, then they are not accepting. Then we are just saying this is just a neuromodulation that will help you to calm you down. Then they are accepting it. So more of cognitive emotional training, they're participating in those training tasks and they're feeling good. And EEG is also associated with it. The session duration is 20 minutes. Pre-EEG and post-EEG is also being associated. So we'll get the report. So, for example, if the machine is not properly kept on the electrodes place, then the machine will get disconnected and the session will not go. But with respect to the other devices, this is not there, and even if it is not properly placed, also the session is continuing. So, thanks to this software that is helping the patients. If at all there is any disturbance, also the session is not going. So we will understand, and as the patient will be visiting our clinic daily, we'll be asking about the compliance of the treatment, the medicines which they are using, and they'll be talking to us once after the session how they are feeling, the feedback after the each session, and that's how whenever I could see the smile in their face, when they're feeling good, when they're coming out of this depression. One patient took only 7 sessions. There she said, "Doctor, I'll discontinue as I'm feeling good." So we said, "That's okay. That's everything. That's up to you." So that's how we have given a free hand for the patients, even if they're not in a situation to come also. Once how much ever they can get it done, so get it done. So that as we are giving this, as this is also a at home session also can be done. But as of now, I have not started at home sessions. So with ease, these integrated sessions are there along with this cognitive emotional training and minimal operational burden. The normal uh, technicians can do this with the in-app guidance support and very less our clinician time. And this is completely an OP setting. And the percentage of patients whom we treat, the percentage of patients who need inpatient treatment is very less in my practice. So I have considered this so that we can give these sessions whenever it is needed. So that's how it can help the patient instead of the admission. So these are the observations from my practice. They felt very good. Early cognitive effects and good mental clarity and executive functioning. And sequencing of response also. Cognitive and affective regulation is improved before we expect the full antidepressant response, and they're feeling better. We have stabilized the patients on 50 mg on fluoxamine in OCD cases without increasing the dose when we have augmented the patients with the neuromodulation from day one. of their treatment. So with less dose of medicine and less number of medicines, we can treat the patients when we add neuromodulation as an augmentation strategy. So this that's what we have observed. So normally when we tell the patients to see me after 15 days, there will be some will not come for the proper follow-ups and also. But when we are seeing the patients for this neuromodulation, very less number of disturbances are there. They're coming and getting this done. And time to stabilization also, before only with the medicines, it used to take for me like 3 months for 100% improvement with maximum doses of the medicines in critical patients. Whereas when I have started this neuromodulation as an augmentation strategy from the day one for patients, those who are accepting and those who are willing, in those patients, it is taking less than 4 weeks time to stabilize the patient. So the what are the indicators of this good tDCS response is early cognitive or affective shifts, improved daily functioning, and reduced need for medication escalation, which I have seen in many cases. And when they're feeling good, I didn't advise them to increase the dose, and I have discontinued after 6 weeks of treatment the medicines. So better tolerance compared to the pharmacological augmentation. Clinical guidelines for using this is careful patient selection. I have taken this as an augmentation strategy for patients, those who are having comorbid depression, anxiety, and other medical comorbidities, and having OCD. So when we give all this rating scales for the patients, when they are having high severe scales, it and they come after like 20 years long latency, 20 years, 10 years of illness, and they're coming to me and saying, doctor, you're my final hope, and coming with severe suicidal thoughts. These patients I'm selecting for the for using this tDCS, so that they can get benefited. And daily sessions, if they're not in a situation to come, we are asking them to come at least on alternate day. So, clear positioning within the treatment algorithm, ongoing and symptom and functional monitoring, and associated with the psychotherapy. So, whenever they are coming, we are doing psychotherapy also. Thank you. We are now open to questions.
We have one question in chat.
Hi, ma'am. Thank you so much for the presentation. Can I ask one question?
Yes, please, madam.
I wanted to know that at what stage do we, understand that now we should recommend the tDCS? And like, is it before prescribing medicine to a new patient or like
After prescribing
simultaneously?
simultaneously, it is better when they are having severe scores in the rating scales, which we give. So, along with the medicines, in the starting of the when they're having severe scores, for example, when they're having mild scores or moderate scores, I have not advised. When they're having severe and very severe scores, along with the depression and anxiety, and having some OCD symptoms in the Vibox scale, so we have started at that time along with the
Okay, so it's
treatment.
like an addition to the
Addition to
traditional
the
treatment.
pharmacotherapy. Addition to the pharmacotherapy, doctor.
Okay, okay. Makes sense. Thank you
Yeah.
so much.
Yeah.
There are some questions in chat if you would like to take them.
No, I can't see that.
One second. So the first question that Dr. Ravitira Innamuri has asked is that he says, thank you for sharing your insights. How many sessions have you been routinely recommending? For example, ECT, we usually say 4 sessions. Are you suggesting 10, 20 sessions usually?
We are suggesting 20 sessions, doctor. Somehow they'll be going back if they are feeling good. Otherwise, they are completing 20 sessions. How frequently they can come and get it done, they are getting it done.
And thank you for that. And you're recommending daily sessions or alternate days, or and you're even this protocol we are being flexible.
Because of this working environment, we are advising daily sessions, and those who are not able to come, we are saying they get at least 4 to 5 sessions in a week, doctor.
Great, because I was listening to one of our colleagues, and he was giving 2 sessions in a day, morning and evening. And I was wondering if collectively we are seeing any accelerated response by giving such.
It's better to give 4 to 5 sessions in a week.
Yeah, perfect. Thank you. Thank you so much.
Thank you, doctor.
Dr. Azmat Ashwant is asking if there are any contraindications for this.
Contraindications, as of now, those who are having a head injury, we have never advised because of that head injury, those who are not having that. And other than that, those who are having seizures, history of seizures, we are saying no. These both are the contraindications for this treatment. Is if they are having any history of head injury or any history of seizures.
Okay, great. Dr. Sawant is asking that how does the side effect profile of tDCS compare to RTMS?
I have not seen much side effects other than the headache, which patients complain. That too, some very few patients have complained headache on the day of the session, after the session, and 6 hours on the next day in the first 6 hours also. Otherwise, that got stabilized with the dolo. So no other issues we have faced with the tDCS. The only problem is coming to the clinic and getting it done, or the feasibility issues are only an issue, but we have not faced any side effects other than headache.
Another question is that how early do you see results?
I'm seeing results in immediately after the session. Patients are saying that they're feeling very calm. So I'm seeing good improvement after 5 days of starting the sessions when they're doing it on a regular basis, like daily one session. After 5 days, we are seeing very good result. Immediately, some patients come and say, "I'm feeling the same. Why I'm not feeling good? Why are you advising?" No, we are telling them, it's like you just continue the sessions immediately. You might not see. Some patients are saying like that also. That I have observed in addiction patients. With respect to anxiety and OCD, I have seen tremendous improvement in from the first session only. Some patients are saying that they are getting all these negative automatic thoughts when doing the sessions, but the intensity of thoughts have come down while we are continuing the sessions. That's how they have explained. So I thought that makes sense. So we need to go with fluoxetine 80 mg, fluoxamine 200 mg, so much, and clomipramine also will be adding. So I felt so in the last 10 years of practice, we have not settled any patient with less dose. That to just 50 mg of fluoxamine in OCD, this is working wonders. So one patient has come down from 36 hours of bathing time to 10 hours with tDCS sessions along with the medications.
That's great to know. Another question from Dr. Gupta is Dr. Gupta is asking, or actually he first complimented and said it was a great presentation. Then he's asking that should we decrease medication when we recommend tDCS or taper it down post
I'm not
treatment?
increasing the dose of the medicines. If I have kept them on escitalopram 10 mg or sertraline 50 mg or so, I'm not increasing the dose of the medicines. For many patients, there is no requirement to increase the dose of the medicine. With the basic dose, when they got stabilized, there is no question of any tapering the doses of the medicines. So after about 1 month or so, when the patient is not coming, we do understand that they quit the medicines. That's how it is.
Okay, awesome. Is there any guidelines to decide this?
Based on our clinical practice only, I'm practicing for the past 6 months. We are seeing good results also.
So Dr. Raviteja Innamuri is mentioning that it would be interesting to study the role of tDCS while de-prescribing medication, like reducing
Yeah,
the.
so for some patients, I kept that. Those who are my previous patients, those who are having mild anxiety and all, those who doesn't want to go with the medicines, I have advised them, okay, you don't want to go with the medicines because they have seen that side effect profile at the time. So I said, that's okay. Just please go only with the neuromodulation, that will help. So we want to see that also. We have just started just a week ago.
Awesome. Abdullah is asking that what all conditions have you seen improvement with tDCS, ma'am?
More of OCD. I'm getting more of OCD patients. OCD cases are getting very much improved with only 50 mg of fluoxamine. So, and the requirement for keeping the risperidone 2 mg also has come down. So, in the first prescription only when we kept, and later on we reduced the doses of the medicine to half after seeing good improvement with along with the tDCS. And depression also we are seeing very good improvement, and anxiety in the first 1 week only we are seeing very good reduction in the scales in the scoring. And we have tried in addiction, but addiction results are not that promising for me as of now, but in these situations this is working well.
Perfect. So I think some of the other questions have been repeating. So I will. Okay. Another question here that is a new one is how do we usually manage patients who come from distant locations?
So that's a very big problem which we are facing right now. So what I am advising is I take at least one session whenever they come, and when they're coming for the repeated follow-ups when we are doing the sessions. But in those cases also, those who are non-residents of the city, those who are just coming for the treatment, those who doesn't want to stay here for the 20 sessions and all, those who cannot afford also, when we are advising one session in every visit, and that is also giving good results. And for me to increase the dose of the medicines also has come down when they are doing, and they are personally saying that they're feeling better of these sessions, and they are accepting it. Nobody is saying no. The good thing is the patient sample, they are saying, they're not saying no. Whenever we are saying, whenever we are, this is something which you have to take it forward and all, they're saying they're having the trustiness. We basically we have to thank our patients because even when we have the resources also, they should be in a situation to utilize the resources. That's how.
Okay. Do we have any other questions? Someone is asking that what is the selection criteria of a patient? I think it's a little overlapping with the previous question.
But those who are having selection criteria, you please go with the rating scales. Those who are having scoring more than severe and very severe, not in the mild and moderate level of depression or anxiety or OCD. Those who are having severe and very severe depression, anxiety, and all, it's better to consider. That is the first selection criteria. And those who doesn't want to go with more medicines, those who want fast improvement, we have to consider them.
Great. So I think, yeah, Abdullah is asking that what are your average charges per session?
We are charging 2000 rupees per session, but for patients, those who are not in a situation to charge to pay that 2000, we are giving 50% discounts also, and they are ready to pay for that. For some with having severe suicidal thoughts, and those who are not staying alone, and those who are those who are not having any caregivers, we have offered free 20 sessions. We have completed 3 patients like that also. So be considerate, doctor. It's not about charging the patient. It's about giving the good treatment at the right time and to the right patient. That makes sense. So that is what is important.
That's great. Any other questions? Okay, while everybody's thinking about it, is there any parting thoughts that you would like to share with us? That any specific patient studies or anything that you'd like to wrap this presentation up with?
Yeah, one patient has come to me that doctor, you're my final hope and all. So after about 20 years of suffering, and father expired, mother is not taking care of him. At the same time, brother also, and he's being working as some back-end operator in the firm, and not getting good charges also. For that patient, we have opted him for the free sessions. And once the sessions are being done, 4 days back he has completed 20 sessions along with the treatment, and his scores are very high. BDI is very high, HAMIA is very high, and YBOX also. So when we have advised treatment for him, and he's very happy along with the tDCS and the medicines, he's very happy. And he's saying, I don't know whether I deserve this or not. Thanks, doc. That's how it is, you know. So sometimes this makes sense when we are putting our leg forward to help these sort of patients. So those sort of patients, I would like to help in the forehand so that they'll be feeling better. And some OCD patients, they have got good treatment. They came here and they have got good treatment. Even when we have opted them that we can send this machine, female patients, that we can send him for female patients, we will send at home sessions and all also. They were like, no, we will come to the clinic and get this done, then that's okay. And they came and they're very happy to come and get the sessions done also. So selecting the patient for the sessions is very important. How they are reciprocating their symptoms and all, and it's better to spend some time with the patient after the sessions so that they can share their thoughts and however they're feeling after each session, so that also makes sense, you know, for the continuing of the sessions.
That's great. Thank you, ma'am, for having this talk with us. And we'll put this up on YouTube so that you can also refer it back, anybody who's attending and those who've registered and were not able to attend. So thank you so much, Dr. Sahithi, for sharing your clinical expertise and telling and discussing the practicalities of using tDCS in your clinic. So that's a wrap, everyone. Thank you so much for attending the first webinar, and see you soon next month for the next webinar.
Thank you so much.